We are back here on Healthy Living. I am here today with Dr. Femi Ajibade. How did I do?
Perfect.
Her name is absolutely glorious and gorgeous, and it means of royalty, which I think is really amazing.
Yeah.
It's a treat to talk to you today. I love having physicians captive, and I love having someone from obstetrics and gynecology captive even more. So may we talk a little bit about your background, where you went to school, and of course I'm curious, is this a passion that you've always had?
So I actually went to boarding school in Nigeria.
Okay.
So my parents wanted me to get in touch with my culture. So
Good for you.
Yeah. So that's kind of like how I'm very in touch with my name and the meanings and all that kind of stuff. And then
Was it English speaking?
Yes. Nigeria is a British colony, so the language of instruction is English.
What a fun opportunity for you.
Yeah.
So did you do that in high school?
Yeah, I did that in high school.
Okay, so so that's super interesting. So then from high school you came back home.
Yeah, and then I went to Emory University in Atlanta, and then for medical school, I went to Meharry Medical College in Nashville, Tennessee.
Okay.
And then I did my residency training in obstetrics and gynecology in Las Vegas, Nevada.
Was it always something that you said?
Yeah.
Medicine was a passion from the time you were little.
Yeah, so I actually decided that I was going to be a doctor when I was 4 years old. I didn't even know how to spell it.
Right.
I spelled it Doctoer, and then... Yeah, and then I was always watching Baby Story and Birthday on TLC and Discovery Channel, and I thought I was going to be a midwife, and I was like, okay, I'm going to deliver babies, I'm going to do all of this stuff, and then I saw this word called obstetrician on TV, and then when I looked it up, I was like, oh, that's the doctor version. I guess I'll just do that.
Oh my gosh, how fun is that?
Yeah.
What is the most challenging thing for you, and what brings you the most joy in your profession now?
I think delivering babies time and time again brings me the most joy. But the most challenging thing for me in obstetrics is the fetal demises.
Okay.
Like when
something goes wrong.
Like miscarriages or there's a term pregnancy that doesn't make it, and you're always like, well, what could I have done differently to have given this woman a live baby? And so a lot of times there's nothing that, like, it's out of our control, but it's always that second guessing, like, how could I have made this a happy story?
So what is the protocol for pregnancy now? At what stage or age? I'm 67, so we didn't even know we were pregnant half the time until 3 months in, right? We just didn't. What does it look like now for a woman from the time she gets pregnant as far as the routine of coming in for appointments?
So when she gets a missed period, she'll call in and she'll have a confirmation visit. That's usually a GYN visit when we confirm, in fact, she is pregnant, and we try to establish the date. She'll get an ultrasound that first visit, and they'll measure the size of whatever they see and try to tell her what exactly her due date is going to be. And from that point, she'll do prenatal labs, and we'll see her in 4 weeks when it's viable.
Got it.
And then we see patients every 4 weeks until they're about 28 weeks. And then at 28 weeks, we see them every 2 weeks until 36 weeks, and then weekly until delivery.
Oh, how fun. Do most people want to know the sex of their baby now?
Yes, a lot of people do, and there is this new screening called Maternity 21. It looks at, like, the mother's blood and looks at the fetal chromosomes that are in it and tries to count them. And that does give you the ability to know the sex of the baby earlier. You can know as early as 9 weeks. Most people are running it at 10 weeks.
Okay.
So most insurances don't cover it if you're under the age of 35, since you're considered lower risk, but you can always pay out of pocket to get this.
So has all that changed? Because I know that, again, at 67, we were having babies at, 20, 22 years old. And now it seems like folks are getting married older, having their children older. Has that shifted what is considered high risk, low risk?
So there are more patients that we are having that are delaying pregnancy into their 30s and early 40s. Advanced maternal age for us is still considered 35 weeks. And we start doing closer screening. We'll do visits with the MUSC, which we have in our office.
Oh, that's great.
They come every Thursday, so we're able to kind of have the patients still come to our office without making a long visit to Charleston, so that they can have a detailed anatomy scan and a consultation. At 40 weeks is where that risk really jumps for pregnancies.
Got it.
Yeah.
And so
not 40 weeks, 40 years old. Sorry.
Oh, at 40 years old. Yeah, 40 weeks.
Yeah.
You and I are like, no, at 40 years old.
At 40 years old is where that risk increases even more.
It's so interesting to talk about that. Now, do you also do gynecology?
Yes, I do also do gynecology.
So what is the recommended age to begin to come in and see you? I told you before, I do a lot of work with adolescents, and I have moms and dads tell me all the time, oh, my kid's 17, and the pediatrician, and I'm surprised if it's girls that they haven't at least had the opportunity to meet with you.
Yeah. So, patients are still okay to see their pediatrician up until the age of 18.
Yeah.
We start our pap smears at age 21, and it kind of varies on provider. 18 to 21 is when we start breast exams.
Okay.
Adolescents are welcome to see us sooner if they wanted things like STD screening, if they wanted contraceptive counseling, they want to manage periods, and those kind of things.
Well, that makes a lot of sense too. Are you finding that folks are pretty savvy? You know, in today's world, when you buy a car or do anything like that, most people really know what they're talking about when they come in. Do you find that we're good stewards of our body? Do we pay attention to our health and wellness?
I think that more and more that we're trying to pay more attention to our health and wellness. I think that there's still a lot of misinformation out there, and that there are people that don't even know what their body parts are called.
Right.
And that it is our job to educate them. So not just getting health care from your provider, but actually learning what it is that we are doing, and what it is that what your medications are for, what we're screening you for, what each exam is looking for. Those are the kind of things that you can ask your provider, and it's our job to explain them to you.
Let me ask you kind of a broad spectrum question. I know that growing up, basically a lot of women's OBGYNs also acted as primary care physicians, quite frankly. Do you find now more that you're much more specialized in sticking with the field that you're in, or how does all that work? In other words, do I need to know, does it help you if I know my numbers in order to be a better physician gynecologically?
I think there are certain things that in terms, like we decided medicine, we're going to chop it up into different parts, but the body still acts as one.
Got it. Okay.
Yeah.
That's smart.
Yeah.
I love that. All right.
So there are things that if I am treating you for a GYN problem,
sure.
There are certain medications that may affect your liver, and if you have liver disease, then I need to know how your liver is functioning, or things that may increase your blood pressure, and if you have high blood pressure, those are things that I need to know. And we do try to communicate with the primary care providers, but with the EMRs and stuff, sometimes that could be a little difficult.
Challenging, sure.
Yeah, so it is helpful for patients to have a general understanding of their health.
What are some of the bigger things that you worry about when someone comes in? For some reason, I know 3 or 4 people who've had gestational diabetes. Is that a pretty common thing that you're seeing these days?
Yeah, so gestational diabetes is pretty common. Usually it's more so the placental hormones are kind of putting the pancreas in overdrive so that it's not able to keep up with the insulin demands of the pregnancy. And so sometimes that can just give us a preview into what things can be after pregnancy, and that there is a risk of developing long-term diabetes even after having gestational diabetes.
Well, 10 minutes, doctor, is just not long enough for us. We need a few shows to iron all this out. So thank you for taking time out today. It's really a treat to get to know you too. And hopefully you'll get to come back and talk to us again.
Thank you for having me. I'd love to be back.
That'd be great. Stay with us. There's more to come.